So let me go to my next set of presentation. It is about do's and don'ts about the posterior capsular tear, and maybe I'd like to have audio for this.
And this is a mature white cataract with a hard nucleus. The last two pieces are to be emulsified. There is a faint line visible posterior to the fragment, and this was suspicious. Now I am left with just the last piece, but the underlying PC tear is staring at me. In my head, I'm thinking I can emulsify this nucleus and there's no need to come out. At the same time, I'm trying to understand the morphology of the tear. The edge of the tear on my left seems to be having irregular edges while the right edge has a straight border. But both the ends of the tear look to have extended up to the equator. At this stage, I'm not sure whether the anterior vitreous phase is intact or not. Now looking at the irregular edge of the PC tear on the left, I thought maybe the anterior is still intact, but the real action happens now, so please don't blink. So did you see? It was like a bomb blast, except for the sound. So let me replay it. The phaco piece comes out and the AC shallows. Now, as the AC shallows, we can see a ring appearing. Now, this is the anti-hyaloid rupture happening and the vitreous prolapsing out. This was a costly mistake. If I had not allowed the antechamber to shallow and if I had injected dispersive OD before coming out, the anterior hyaloid rupture and the vitreous prolapse could have been prevented. I assumed that the anterior hyaloid was ruptured looking at the configuration of the left margin of the posterior capsular tear, which was incorrect. The rule of not allowing the chamber to shallow while withdrawing the infusion should always be followed. It is sacrosanct. So the moral of the story, the secret is in the chamber. Bimanual antivitrectomy is performed. And a multi-piece hydrophobic IOL is placed with both the haptics in the sulcus and the optic pushed back behind the rhexis to achieve the optic capture. The second case, again please don't blink. I'm trying to hydropolish. There is a positive pressure. The patient moves his eyes just a bit and then this happens. Well, did you see what happened? Let me replay that. There is a small posterior capsular tear to begin with, and then it enlarges. And after a second or two, there is another ring developing. This is the anterior hyaloid rupture and the vitreous prolapsing out. So this case teaches us that posterior capsular tear and the anterior hyaloid rupture are two independent entities. If we are alert, we can prevent the rupture of the anterior hyaloid in spite of having a PC tear. The only critical aspect is very early diagnosis of the PC tear. Now this is a case of a posterior polar cataract. The posterior capsule is broken, but the chamber is never allowed to shallow. The eye is constantly replenished with OVD and the anterior hyaloid rupture could be prevented and the IOL could be successfully placed in the bag.
So the take-home message is that when you have a posterior capsular tear, the first thing to do is never come out. Always inject viscoelastic through your non-dominant hand. One tip I'd like to share with you is many times the younger surgeons would find it difficult to push with the left hand or non-dominant hand. You can just hold the cannula in the wound and ask your assistant to push it for you. Okay, that is a good way to because otherwise you'll be too stressed when you're trying to do it. Your hand will be shaking. Just ensure that the cannula is tight enough. Go inside, hold it in the edge, and ask your assistant to push. It can be done in a very controlled manner, and then you come out. So eventually you learn how to do it yourself. Until then, so remember, first thing is diagnose the PC tear early. If you can diagnose PC tear early, you can prevent the anterior hyaloid rupture in majority of the cases. That's a challenge. Majority of times what happens, the diagnosis is so much delayed, you lose the opportunity to prevent the anterior hyaloid rupture. and this is how it would look like. So doing on to the next, now once you have ruptured the anterior-hyaloid and now you are in a position to do anterivitrectomy. Now let us understand, how do we prevent enlargement of the posterior capsular tear during anterivitrectomy? Dr. Vasavda has taught us, like, the best way to do the anterivitrectomy is always, if you go and do it through the pars plana approach, the chances of the PC tear enlarging is minimal because you're going to attack it from the posterior aspect, and the chances of enlarging is very minimal. So this is the ideal way to go ahead and do it. But in certain situations, like when you're doing a topical anesthesia and other things, that becomes a little bit of a challenge, and many of us would not be so well versed to make a trocar cannula incision. In those situations, I would recommend just do a small peritomy and use a MVR blade and directly go in. That is a much better way to do rather than the trocar cannula way for at least the anter-segment surgeons until we get used to it. Now, my question is, can we achieve similar goals using the translimbal route? It is possible in certain situations, and let me just share a few cases, like, few tips how to achieve this. So the first thing what we need to do is, maintain the chamber. The same thing. The first step is never allow the chamber to shallow. Okay, that is the first thing, because you're losing the anterior-hyaloid ruptures, the vitreous prolapses out. It is going to enlarge the PC tear still further. So allow it to minimize, even if the vitreous is already come. By putting in viscoelastic, you are preventing it from enlarging. Don't overdo it. Rather, I should say, just enough to maintain the chamber. And the choice of OVD is always going to be dispersive OVD. If you don't have anything, just put anything you have. The next, before you start doing a vitrectomy, watch the bottle height. You don't want an overly pressurized eye, because if you want to decrease the infusion, just enough to maintain. If you start with a 90 centimeter, you're going to blow it open just like this. There is a sudden deepening of the chamber, and the infusion itself is going to enlarge your posterior capsular tear. So remember, because when you're doing a cortex aspiration, the bottle is at 100 centimeters, suddenly you go this thing. The next would be the principle, like, you can utilize this principle of trying to place the cutter at a slightly deeper plane, like how we go through the pars plana approach. And I believe that if you can cut the, segment the vitreous into two different parts, like, the one which is behind the posterior capsule and one is above, the chances of, enlarging the posterior capsular tear during the vitrectomy can be achieved. So let us see this example through a couple of cases here. So, let me just go through this graphic one more time here. So what I'm doing here is, so once you're done, this is the posterior capsular tear. Look at the position of the cutter first. The cutter is placed below the posterior capsule level with its bevel facing down. Okay, so initially it is we're going to cut the vitreous from facing towards the optic nerve rather than anteriorly. Once you cleared off that amount of vitreous, that's then you're going to turn the bevel sideways and then anteriorly, and then deal with the prolapsed vitreous, which is actually not attached to its base now. So by doing this, like, segmenting the vitreous into two parts, there is a lesser likelihood of increasing the posterior capsular tear. So let me take you through one of these cases. Now this is a case where you can see a PC tear has happened, and I can also see a anterior-hyaloid rupture which is there. Now two rings are seen, and the vitreous is already there. When I try to overfill with OVD, you can see that literally the vitreous is now prolapsing more out, and it is directing towards the wound. That's what we could see here. So the round circle which was there initially has disappeared now. So the anterior rupture is complete and vitreous is prolapsing out. The first thing is you go in and put diluted triamcinolone acetate. It's challenging to distinguish vitreous from because you already put in OVD, but always there will be some hint that where the vitreous fibers would be. Now, because the chamber is already formed, I'm not even going with my infusion. Look at the bottle height. Bottle height is kept at 20 centimeters. The first you go inside, and then the infusion comes in later. The bevel now I'm positioning is posteriorly, just perform the vitrectomy at that stage. And then once you are sure that, now how do you know that the vitreous around the posterior capsule? Watch for the fluttering of the posterior capsular margin. Once that fluttering is stopped, that indicates once it starts to flutter, that indicates that it is not having any coating of vitreous around it. So you continue until you see that thing, and then at the last moment you turn the tip sideways and then anteriorly. So we were successful in preventing the enlargement of the posterior capsular tear even when you're doing an antivitrectomy until now. But still the job is still not done because it is not a perfect rhexis there. So whenever you're trying to implant an intraocular lens, that free edge can again tear and enlarge into a bigger tear. So that's the reason why it's better if there is an opportunity always to convert the rhexis into a posterior capsular rhexis, and this allows us to implant the lens very much in the bag. And this is what I'm trying to do it here. Remember, when you're done a vitrectomy, the eye is very soft, and in some of these patients post vitrectomy, doing the rhexis itself becomes a little bit of challenge. So if you can, to conclude, if you follow the right principles of identifying the PC tear at the earliest, you have the highest chance of placing the same lens into the bag itself. There need not be any change of your plan. If you can identify the PC tear earliest, you can minimize the anterior halide rupture. Even if the event of an anterior halide rupture, if you diagnose it earlier enough and if you followed the right principles, you still have a great opportunity to put the same lens in the bag. In the last resort, always you have an opportunity to place the lens in the sulcus as well.